Hello, the topic of our webinar today is on what clinicians need to know about available therapeutic options for COVID-19. MiOra, as you know, is a nonprofit organization whose mission is to provide an opportunity to students to conduct cutting-edge health and STEM research through no-barrier experiential certificate internships. The founder and president, Dr. Oslim Equals, is a pediatric infectious disease specialist, and the presenter today is going to be myself. I am David Solorio. The objectives for today are describe the current trends of COVID-19 in California, discuss the testing options in patients at high risk for COVID, describe the outpatient management and available therapeutics for the outpatient management of COVID, describe the rebound, data on prevention of severe disease, and data on long COVID. And lastly, discuss where to find more information about COVID-19 therapeutics and availability. To start with the weekly trends of COVID-19 cases and deaths in California, this is the data from the CDC as of January 4th, 2023, depicting weekly case rate of 158 per 100,000 and weekly death rate of 0.8 per 100,000. Now, looking at the surveillance data from the CDC from the variants of concerns in California, as of January 7th, 2023, the Omicron BQ.1.1 lineage makes up to 40.6% of the circulating variant, and the other lineages, such as the XBB, is still trailing behind around 7%. Data from the CDC through January 3rd, 2023 shows a 7-day moving average of around 767 new hospital admissions. COVID testing in California still continues. However, the period through January 2nd, 2023, the CDC does not provide the percent positivity, which is the percentage of all the coronavirus tests performed that are actually positive. Also, for the period ending in December 29th, 2022, the CDC does not provide the data for all the tests performed. This slide illustrates the risk factors for severe COVID, which include age, which is the strongest risk factor for severe COVID outcome and risk for deaths, being 20 times higher in people 50 to 64 years as compared to those between 18 to 29 years, with the risk increasing substantially at 65 years and above. 2. Underlying conditions: obesity, diabetes, chronic kidney disease, chronic obstructive pulmonary disease, neurocognitive disorders, and other diseases increase the risk of severe high COVID. Risk for progression and poor outcome increases with the number of underlying conditions. And number 3, race and ethnicity. People from certain racial and ethnic minority groups are more likely at a younger age to experience severe COVID as barriers to accessing healthcare, and it is more common in certain racial and ethnic groups. This slide illustrates the key findings from one large cross-sectional study where the COVID-19 death risk ratio was highest for select age groups, like over 85 years, as marked as with green, which further emphasizes the fact that age is the strongest severe factor for COVID-19 outcomes. The study also demonstrated that the risk ratio or deaths being higher in individuals with underlying comorbid conditions as indicated in blue. The depiction in this slide from the same large cross-sectional study reiterates that the death risk ratio increases as the number of comorbid condition increases. Now we will move on to medical management for mild to moderate COVID infection, where primary care physicians play a key role to help reduce the risk of hospitalizations or deaths in high-risk patients. We will discuss the authorized and approved therapeutics for the treatment of mild to moderate COVID infections in adults and children with positive results for the SARS-CoV-2 viral testing, who are at high risk for progression to severe COVID, including hospitalization and death. Let us find the first step back to see the available tests for SARS-CoV-2. The tests include molecular tests such as PCRs that detect the genetic material of the virus and rapid antigens that detect specific proteins in the virus. Patients reporting a positive rapid antigen test or PCR are eligible for therapy. To note, PCR is not mandatory for therapy. Paxlovid has not yet been approved, but has been authorized for emergency use of FDA under an EUA for treatment of mild to moderate COVID-19 in adults and pediatric patients 12 years of age or older weighing at least 40 kilograms with positive results direct SARS-CoV-2 viral testing. Paxlovid contains nirmatrelvir and rentavir, which is a strong inhibitor P4053A. It is generally administered in a dose of 300 milligrams to 150 milligram tablets, with one tablet given twice daily for 5 days. One carton contains 5 blister packs of Paxlovid as co-package and tablets for providing required doses in a full 5 treatment course. From a timing perspective, Paxlovid should be started as soon as possible after COVID diagnosis with 5 days of symptom onset. Special recommendations and considerations for Paxlovid will include renal impairment, where special packaging is available for patients with moderate renal impairment. Paxlovid is not recommended when patients with severe renal impairment. Hepatic impairment, where Paxlovid is not recommended in patients with Child-Pugh score C, which refers to advanced hepatic dysfunction. Potential drug interactions, the details of which we'll review in the subsequent slides. Paxlovid is contradictorated with drugs that are highly dependent on CYP3A for clearance and for which elevated concentrations are associated with serious and/or life-threatening interactions. The drug interaction resources for providers has been added to this slide for detailed reference. This slide provides the details of the common drugs which can be co-administered with dose adjustments or with increased monitoring. This list includes commonly used acid-reducing agents, allergy meds, antibiotics, pain medication, immunosuppressants, drugs used for diabetes, high cholesterol, and some respiratory conditions. Switching gears to our next therapeutic option, Velcuri, commonly known as remdesivir, a nucleotide analog RNA polymerase inhibitor approved by the FDA in adults and children 28 days and older weighing at least 3 kilograms. This medication can be administered by IV infusion in non-hospitalized patients as a single loading dose, 1 day followed by once daily maintenance of doses on day 2 and 3. Again, from a timing perspective, remdesivir or Velcuri should be started as soon as possible after COVID diagnosis and within 7 days of symptom onset. Special considerations will include severe renal impairment, where it is not recommended, hypersensitivity reaction, where patients need to be monitored or closely during infusion for at least 1 hour after the infusion is complete, potential antagonistic effect of chloroquine on the antiviral activity of Velcuri. Moving on to our last therapeutic option, Lagevrio, commonly known as molnupiravir, is a nucleose analog that inhibits SARS-CoV-2 replication by viral mutagenesis. It is an emergency use authorization drug limited to patients for whom alternately COVID treatment are not accessible for clinically or appropriate. It is not authorized to be used for patients 18 years of age and under. The dose being 200 milligram capsules taken orally twice a day for 5 days. Timing-wise, Lagevrio is used as soon as possible after diagnosis of COVID-19 and within 5 days of symptom onset. Special considerations for Lagevrio include not recommended use during pregnancy given the risk of embryo-fetal toxicity, not authorized for use in patients under 18 years of age given the bone cartilage toxicity. Contraception is needed in females for the duration of the treatment and for 4 days after the last dose in males, and males for the duration of treatment 3 months after the last dose. Currently, the LA County Department of Public Health has implemented a plan to assist those eligible for treatment, including criteria and pathways to access the medication. This plan includes ways for individuals to find urgent care centers, test to treat sites, and pharmacy. To be eligible, a person must be at elevated risk for severe illness and hospitalization, including the following. COVID-19 positive individuals must be 50 years and older, or those are unvaccinated or not up to date with current COVID-19 vaccinations, and or must have one more health condition that may be associated with severe illness regarding vaccination status. The list of conditions is set by the CDC and includes a number of conditions from chronic liver disease to neurological conditions, diabetes, and more. The extensive review of each of the medical conditions can be found on the link on this slide. LA County Department of Public Health has ensured that county residents are able to access medicines regardless of insurance or healthcare access by providing county nursing staff who screen via call center and telehealth services. These services are provided over the phone 7 days a week from 8 a.m. to 8:30 p.m. This is a great resource for the doctors and clinics that are able to see patients due to insurance issues. We will now spend a few minutes on COVID-19 rebounds. So what is a COVID-19 rebound? This is when patients with COVID-19 start to get better and begin to get symptoms 2 to 8 days after they have recovered and may test positive again. This rebound has been seen in many patients who have received treatment, as well as those who have received no treatment for COVID-19. Paxlovid, one of the frequently used medications, has been associated with COVID-19 rebound. The good news is that there's currently no evidence that additional treatment is needed for the rebound, and these reports do not change the conclusions from the Paxlovid clinical trial, which demonstrated marked reduction in hospitalization and death. However, electronic health record data analysis may fully characterize the incidence and risk of disease and progression associated with the rebound, and more prospective data will be needed to fully understand the pathophysiology association with the drug treatment. Please feel free to access the share link from the CDC Health Discovery and Advisory on COVID rebound after Paxlovid treatment. Data from the CDC shows 1 in 13 adults in the US have long COVID symptoms, which are defined as symptoms lasting 3 or more months after contracting the virus, those symptoms which they did not have prior to COVID infection. 3 times as many adults have been between ages 50 to 59 have long COVID than those at 80 years and older. Black and Hispanic individuals were more likely to experience long COVID-related symptoms and health problems compared to white individuals, according to a new study. Up to 180 days after testing positive, Black patients who have severe COVID-19 had higher odds of being diagnosed with chest pain, diabetes, and headaches compared to white patients. In addition, Hispanic patients who have severe COVID-19 were also more likely to be diagnosed with headaches as well as dyspnea compared with other patients. Also, there's 3 times as many adults between 50 to 59 with long COVID than those that are 80 and older. While bisexual and transgender adults were more likely to have current long COVID symptoms than adults of other sexual orientations and gender identities as well. The prevalence of current long COVID symptoms is still differing from state to state. This slide provides the links of helpful information and resources for the reference in particular to test, to treat site locator, general therapeutics locators, and CMS reimbursement information for other antivirals. Let us now conclude with this webinar with the self-knowledge check question. Based on current supply, COVID-19 therapeutics should be considered for any COVID-19 positive patient who meets which one of the following criteria? A, has mild to moderate symptoms and are within 5 to 7 days symptom onset. B, due to current supply constraints, COVID-19 therapeutics should be considered only for individuals who are severely immunocompromised. C, no additional criteria needed. D, has one or more risk factors for severe COVID. E, A and D only. The correct answer is E. The reason for this is because oral antivirals are not currently supply constrained. Clinicians should consider COVID-19 treatment in non-hospitalized patients who meet all of the following: test positive for SARS-CoV-2, have symptoms consistent with mild to moderate COVID-19, are within 5 to 7 days of symptom onset, and have one or more risk factors for severe COVID-19 illness. Thank you. We appreciate your attention to this webinar, and we would love your feedback.